Hi, my name is Dr. Sylvia Choi, and I'm an Associate Professor of Pediatrics at the University of Pittsburgh School of Medicine, and I'm a hospitalist at Children's Hospital of Pittsburgh of UPMC. I'm going to be speaking to you today about common childhood disorders, namely enuresis, encopresis, and abnormal sleep. So we'll start with enuresis. By the end of this lecture, you should be able to describe what enuresis is, discuss the demographics of monosymptomatic enuresis in children, evaluate patients presenting with monosymptomatic enuresis, and determine appropriate treatment strategies for patients with monosymptomatic enuresis. So we're going to start with an overview. First, I will define enuresis and review the demographics and what we know about the etiology of monosymptomatic enuresis. I will then cover the evaluation and treatment of patients that you may encounter in your office practice. So let's start with two cases. The first is a mother who brings in her son and says, "My 8-year-old has his first Boy Scout camping trip in a month, but he's worried that he may wet the bed. His bedwetting is slowly improving, but not fast enough. Is there anything he can take to prevent this?" The second case is another mother who brings in her son and says he pees all the time and has accidents at night. Does he have diabetes? So what is enuresis? Enuresis is actually derived from the Greek word enurin, which means to urinate in. Enuresis is the intermittent incontinence of urine while asleep in a child greater than 5 years of age. And there are two different types of enuresis. Monosymptomatic, where there is enuresis with no other lower urinary tract symptoms and without a history of bladder dysfunction, and non-monosymptomatic, which is enuresis that has other, mainly daytime, lower urinary tract symptoms. Non-monosymptomatic enuresis can have symptoms of increased daytime urinary frequency, urgency, straining, dribbling, poor void, post-void dysuria. The causes are really varied. It can be related to constipation, vesicoureteral reflux, urinary tract infection. And really for the purposes of this talk, I'm going to be concentrating on monosymptomatic enuresis. So it's a very common childhood disorder. And as you can see from this graph, while it starts out at about 15% of 6-year-olds, the incidence decreases with age. About every year, 15% will outgrow their enuresis. So by the time they're adolescents and adults, the incidence is down to 1 to 2%. It is more common in boys than in girls, and happens to be more common in patients that have ADHD. So what is the pathophysiology of monosymptomatic enuresis? For these patients, bedwetting occurs because for some reason the child does not wake from sleep when they sense the urge to urinate. And this can be from several causes. We'll go over each of these individually. Small bladder capacity is a very common reason why children may have monosymptomatic enuresis. The expected bladder capacity of an infant is about 2 ounces. And then this expected bladder capacity increases. And a nice rule of thumb is that for every age in years plus 2, that should be the expected bladder capacity in ounces. So if you're 6 years old, 6 plus 2 is 8 ounces, should be your expected bladder capacity. And that rule holds until you're about 10 years of age. Once you get to be 10 or older, your expected bladder capacity is about 10 to 15 ounces. So you can determine if somebody has a small bladder capacity by having the family do a voiding diary. Often children with small bladder capacity will have frequent small volume voids, and the volume of these voids tends to be less than half of what their expected bladder capacity would be. And when you track them over a 24-hour period, the largest urinated volume for them tends to be less than 65% of their expected bladder capacity. Another cause for monosymptomatic enuresis is nocturnal polyuria. This is excessive urine production at night. Normally, urine output decreases at night because we have increased antidiuretic hormone secretion. It's likely that ADH decreased secretion or sensitivity to it is likely different in children with nocturnal polyuria. There are some studies that suggest that there's a decrease in the actual secretion, but this has not been proven in multiple studies. It's likely somehow also related to small bladder capacity because we know that ADH secretion increases with bladder distension. And how you know if someone has nocturnal polyuria is if they have a history of very large volume bedwetting. overactive bladder is another common cause of monosymptomatic enuresis. This is when patients have a sense of urgency when they have a full bladder, and they get abnormal bladder contraction as their bladder fills. The children try various maneuvers to try to suppress this urinary urgency. They can do things like contracting their pelvic floor muscles like the child in figure A by crossing their legs, or what is known as the Vincent curtsy sign, where they crouch down and they press their heel typically on the perineal floor to stop themselves from wetting. Children with overactive bladder tend to have significant urinary frequency, usually going more than twice per night or more than 8 times per day. Genetics also plays a big component in monosymptomatic enuresis. Unfortunately, if both of your parents have nocturnal enuresis in their history of childhood, you have a 77% chance of having it yourself. If only one parent had a history of nocturnal enuresis in childhood, that risk goes down to 44%. And if neither of your parents had a history of nocturnal enuresis, you only have a 15% risk. We know that with monozygotic twins, there's a 68% concordance versus only 36% for dizygotic twins. There have been various chromosomes, including 12, 13, and 22, that have been identified as potential gene loci for enuresis, but one specific gene has not yet been identified. Sleep-disordered breathing is another cause for nocturnal enuresis. It's really unknown whether enuresis happens during REM or non-REM sleep with patients, and it doesn't necessarily appear to be more common in children that experience parasomnias. But parents do report that these type of children tend to be much harder to wake from sleep. They say that they're really deep sleepers. And we know that patients that have sleep-disordered breathing often can have enuresis because they're not having normal sleep and so they lack normal arousal. So the history you need to obtain in the office has to clarify for you whether this is monosymptomatic versus non-monosymptomatic nocturnal enuresis, since the evaluation and treatment is really very different. Patients with monosymptomatic nocturnal enuresis have a history of never having been completely dry at night, whereas those children that have non-monosymptomatic will often have been dry for 6 months or more before they start to have bedwetting. We know that if a child has had continence at night for 6 months or more, you really do need to worry more about bladder dysfunction or dysfunctional voiding, and you want to get a very careful history of any daytime urinary difficulties. You also want to investigate if there are any other comorbidities, such as constipation, which is not associated with monosymptomatic enuresis, or even developmental delay. You also want to know their drinking habits. Are they drinking any caffeinated beverages, especially close to bedtime, which could certainly make them more prone to having increased urinary output at night? And do they tend to drink most of their volume in the evenings after school? A sleep history is important. Do they snore? Are they a very restless sleeper? Something that would suggest sleep-disordered breathing. And you want to know what their bedtime routine is. Does their bedtime routine include a drink of water right before bedtime? That probably wouldn't be such a good idea for somebody that's having nocturnal enuresis. And then you obviously want to get a very good family history, since we know that genetics plays a big component in children that have this. Your physical examination is really important. You obviously want to look at your growth parameters. A child that has poor growth could possibly have renal disease that you haven't diagnosed before. A careful genital exam is important to make sure the child doesn't have hypospadias or perhaps even labial adhesions that is impairing their voiding. A good perianal exam to look for evidence perhaps of constipation with smearing or fecal soiling present. And then you want to do a careful back exam. This shows a child that has clearly a sacral dimple as well as even a tuft of hair that should suggest perhaps an underlying spinal dysraphism, which may mean that this child has a neurologic reason why they are having inability to have bladder control. On your abdominal exam, you would want to assess for any retained feces with maybe a mass in the left lower quadrant. On the oropharynx, as you can see in this picture, you would look for tonsillar hypertrophy, which could suggest obstructive sleep apnea. And then a careful neurologic examination to make sure they have good reflexes and strength in their lower extremities, and not somebody that you're worried has a neurologic reason why they lose bladder control. So there aren't a whole lot of diagnostic tests that you need to do for somebody presenting with monosymptomatic nocturnal enuresis. You do want to do a urinalysis. That's a pretty simple test, and it'll tell you a lot of information. If their specific gravity is very low, perhaps this is a child who has diabetes insipidus. If they have glucosuria, you may be looking at somebody who has diabetes mellitus. Evidence of pyuria or bacteriuria could let you know that perhaps they have urinary tract infection. And then the other sort of test that is important to do is to have the family do an elimination diary. You want to have them mark down the maximum voided volume in 24 hours over 3 to 4 days in terms of their urine, so you get a sense of what the child's urinary volume is in terms of production. You also want to know how frequently are they voiding and how much are they voiding each time. Now this can obviously be difficult in children that go to school, so picking a weekend to do this when they'll be at home normally can be very helpful. You want to record bedwetting episodes for 7 consecutive nights, and if you're able to get a sense of the volume voided, that can be helpful to let you know if the child may have nocturnal polyuria. You also want to record their stool output, since for children with non-monosymptomatic enuresis, they often will have constipation that's causing this. And then you would like them to record their fluid intake, both the volume of fluid, when they're drinking it, and what types of fluid they're drinking. So the treatment. The International Children's Continence Society in 2006 came up with recommendations for the management of bedwetting in the primary care setting. The treatment really starts with reassurance and education. Then it also covers lifestyle changes and 2 first-line treatment options. Now, you really need to assess who in the family is most interested in treatment, because you really need to have buy-in from all of the involved parties in order for treatment to be successful. You want to reassure the family and the patient that this is a very common problem that many children suffer from. You want to let the family know that this is not intentional, so punitive therapy is really not helpful. Now, this doesn't mean that the child should not participate in cleaning up after themselves if they have an accident. But beatings of children or withdrawing of positive reinforcement has never been shown to be very helpful because they're not doing it intentionally. And over time, spontaneous resolution happens in most patients. So just letting families and patients know this can make things a lot better for them. In terms of lifestyle, we know that the child needs to drink adequate fluids, so we don't want families to say, oh, I'm going to fluid restrict them. But you want to really try to encourage them to drink most of their fluids during the day. So 2/3 of their fluid intake should really be during the day, and you should limit the fluids during the evenings to 1/3 of what their daily maintenance requirement would be. Ideally, they would have no fluid for the hour before bedtime, and you want to have a very stable bedtime routine where the child is practicing emptying their bladder fully before bedtime. And if for some reason they wake at night, they should go and try to urinate on the toilet so that they empty their bladder completely before they go back to sleep. So the first line intervention that has the best long-term cure rate is an enuresis alarm. Again, you really need to make sure that the family is on board with this, because the way that the alarm works is it wakes the child when they have an accident, which means the parents wake up. So if the parents don't want to be woken, or the child doesn't want to be woken, this can actually add significant stress to the family. So the alarm alters the sleep arousal when the child voids. It makes a loud beeping noise typically, and if the child is such a deep sleeper that they don't wake to the alarm, the parents typically wake. Then the parents should wake the child, have the child go to the restroom and try to urinate. Then the child can help change their bedding and they can return to bed. Now, this is not a quick fix. Ideally, you would have the family use it for 2 to 3 months before you decide if it's been effective or not effective. Like I said, it is actually probably the best treatment for children that have monosymptomatic enuresis, and it does have the best long-term cure rate. Once you think that it's been effective for your child, you want to continue it until they've been dry a minimum of 14 nights. There are different types of alarms. There are some, they all have sensors in the underpants themselves that sense when there is wetness. Some of them have the alarm unit that's clipped to the child's shirt. Some have a wireless remote and the alarm goes off in another area. So you could even have the alarms where the parents are sleeping so that they can be woken as well. The second first-line treatment that's been used and is effective is desmopressin. As you all know, desmopressin is a vasopressin analog, and it works to directly decrease nocturnal urine production. So it often works, and when it works every single time it's used. Up to 40% of children will have a partial response, and 20 to 30% will be totally dry. The problem, though, is it's only effective on the night that you use it. So it's not like the enuresis alarm, where over time the child will learn to be roused when they have the sensation that they need to void. So this does have a much higher relapse rate than the alarm. There's a nasal spray, but that actually is associated more with hyponatremia. So most physicians prefer the fast-melting desmopressin preparation. When you use this, you really want the child to try to take a drug holiday about every 3 months, because we know the natural history is that most children will outgrow this over time, and you don't want to keep them on it if they don't need it. Ideally, the child would take this an hour before bedtime to allow time for it to have effect. And you really have to restrict their fluids because of the concerns of hyponatremia. So you choose the treatment based on what you think is causing the problems. If you think the child has a small bladder capacity, then they would actually do best with an enuresis alarm, because that will train them to sense the sensation that they have to void and to wake. If your child has nocturnal polyuria with a normal bladder capacity, then they would actually do well with DDAVP, because the DDAVP would decrease the urine production at night, and they would be able to hold the normal amount of urine in their bladder. If the child has normal bladder capacity and normal urine output, then they can use either the alarm or a DDAVP. And again, the alarm will actually give them a longer cure rate than the DDAVP. If you have a child who has a small bladder capacity and they have nocturnal polyuria, then this child probably needs both the alarm and DDAVP to be successful. There are second-line agents, anticholinergics, that can increase the functional bladder capacity and have been used as adjunctive therapy for kids that have small bladder capacity and overactive bladder in conjunction with DDAVP. And imipramine has also been used. It has a lower response rate than DDAVP and a higher relapse rate, and there's a risk of prolonged QTC. So most people feel more comfortable recommending the alarms or DDAVP and not necessarily going to these second-line agents. So let's get back to our cases that we started this talk with. If you remember, case number 1 was an 8-year-old who had his first Boy Scout camping trip coming up. So he's been previously healthy, full-term, 8-year-old black male who's had nocturnal enuresis, has never been dry at night completely, and he's been slowly improving, but he still wets on average 3 nights per week. He stools daily, typically after dinner, and it's a very normal consistency. He has no daytime urinary symptoms. In fact, what's interesting is he doesn't typically even urinate at school. He's not a big breakfast eater, and although he packs his lunch, it turns out he doesn't buy a drink at school because he thinks the line is too long. So he drinks a lot after school and in the evenings. When he has an accident, he always wets through the pull-up. And his father himself wet the bed until he was approximately 12 years old. The child's physical exam is completely within normal limits, and his father thinks that the son is going to outgrow this just like he did, but he wants him to be able to go on the camping trip. And the kid can't even wear a pull-up because he'll wet through it if he has an accident. So his history is really most suggestive of nocturnal polyuria, and it's worsened because he's drinking most of his fluids in the afternoon and the evening. So he would most likely benefit from changing when he's drinking most of his fluids and from using desmopressin. Case number 2 was the little boy who, quote, pees all the time, and his mother wanted to know if he had diabetes. So he's a 10-year-old white male, previously healthy, who did take longer to toilet train than his older sisters, but had not had any daytime accidents since the age of 5. But he continued to have nighttime accidents more than half the week. He has a normal stooling history and a normal dietary history, so no polydipsia or polyphagia. He is noted to pee often. He urinates in the morning after waking and after breakfast, before lunch at school and after recess, when he comes home from school, sometimes twice before dinner and once after dinner and once before bedtime. He wears a pull-up at night, and he doesn't typically wet through the pull-up. His father is not involved, and his mother is really unaware of any history of him being a bedwetter. His physical examination is completely normal, and his mother initially thought that he was just a late trainer, but now she's worried that he might have diabetes because he pees so often and he's wetting the bed. Well, this child's history is really suggestive of someone with a small bladder capacity. And so he would benefit from some lifestyle modifications, but also a bedwetting alarm will ultimately be more successful for him. So with these simple maneuvers, you can actually really help a lot of your patients outgrow their bedwetting. Now I'm going to move on to encopresis. By the end of this lecture, you should be able to describe what encopresis is, discuss the epidemiology of functional fecal incontinence in kids, know how to evaluate children presenting with this, and determine appropriate treatment strategies. So first I will define what encopresis is, discuss the epidemiology and etiology of functional fecal incontinence in children. Then I will cover the evaluation and treatment of patients that you may encounter in your office. We'll start with 2 cases of patients presenting with fecal incontinence. Case number 1, the mother complains that her son has had diarrhea for the last 3 months and is starting to have accidents in his underpants. He's a 10-year-old black male with no significant past history who had a stomach flu 3 months ago. His fever and his decreased appetite resolved, but his diarrhea persisted. And now, after researching his symptoms on the internet, his mother's worried that he has inflammatory bowel disease and wants to see gastroenterology. The second case is a daughter who's brought in by her mother because she's having abdominal pain and her belly is getting big, and the mother wants a pregnancy test. She's a 16-year-old white female who's had no significant past history, who for 3 months has had intermittent daily crampy, periumbilical, and abdominal pains, 2 weeks of fecal soiling, and she appears bloated. So what is encopresis? This is also from a Greek word, kropros, which means dung. Fecal incontinence is actually the preferred term, and this means repetitive passage of stool in inappropriate places by children who are chronologically and developmentally greater than 4 years of age. Because although most children achieve fecal continence earlier than 4 years of age, the majority of them do by 4, unless they're developmentally delayed. Now, because of this, we don't consider it to be encopresis unless they are greater than the age of 4, because it could still be developmentally normal. The amount of stool passed can vary. It does not have to be a large amount to be considered encopresis. So fecal incontinence, there's true incontinence, which is known as organic fecal incontinence, and pseudo-incontinence, which is functional. And functional fecal incontinence can be divided further into retentive and non-retentive. More than 90% of patients that have fecal incontinence have functional rather than organic incontinence. Organic fecal incontinence, this is true incontinence. These are patients who really will never be able to attain fecal continence for a variety of reasons. Very commonly, it's due to anatomic problems, such as an imperforate anus, like is here in this picture, or Hirschsprung's disease, as you can see from the x-ray on the right. Patients that have neurologic disorders also have difficulty with fecal incontinence, such as kids that have cerebral palsy or children that have spina bifida. For the purposes of this lecture, I'm going to focus on functional fecal incontinence, which is the term that we use to describe patients who are physically able to be continent, but who experience fecal soiling. As I said already, functional fecal incontinence can be divided into 2 types: retentive, that's associated with functional constipation, and non-retentive. Non-retentive fecal incontinence is when children have no underlying disease or concomitant constipation, but they have fecal soiling. This is, in some studies, up to 20% of children that have functional fecal incontinence, and there's a strong association with diagnoses like ADHD or anxiety. And often the episodes of fecal incontinence can be associated with a specific trigger, like being in a situation where they maybe had experienced trauma. For the purposes of this talk, I'm going to really focus on retentive fecal incontinence, which is incontinence that is associated with constipation. In 2006, there was a working group of pediatric gastroenterologists, and they published what is now known as the Rome 3 criteria for functional constipation. This is for children who are 4 years of age or older, and they are considered to have functional constipation if they have at least 2 of these following symptoms for at least 2 months: less than or equal to 2 stools per week, greater than or equal to 1 fecal incontinence per week, retentive posturing or excessive volitional stool retention, painful or hard bowel movements, a history of large diameter stools, or the presence of a large fecal mass in the rectum. Now, we use actually the same diagnostic criteria for infants and toddlers, but their symptoms only need to be present for 1 month's duration in order for them to be considered to have functional constipation. When we look at the demographics, constipation is common, fecal incontinence is a little bit less common, but still affects up to 3% of 4-year-old children and about 1.5% of 10-year-old children. It usually starts by the age of 7, but remember, we don't usually call it fecal incontinence before the age of 4. And of children that suffer from fecal incontinence, 80% are retentive as opposed to non-retentive. And unfortunately, parents and families often don't disclose this because they're really embarrassed and they think they're the only one who has this problem. So in terms of pathophysiology, stool, as you all know, has a lot of water in it. And as it passes through the colon, more and more water is absorbed, forming solid stool. The stool goes into the rectum, passes through the internal anal sphincter, and is then held in the anal canal. We have voluntary control of the external anal sphincter, and this allows us to release stool at appropriate times. So what can happen is if for some reason we withhold the stool, either because we had a painful stool and now we don't want to pass, or we're in school and we don't want to use the school bathrooms, but we voluntarily withhold, we stiffen, we strengthen our legs and contract our gluteal muscles, and that pushes the stool back up into the rectum. Then, as the stool sits inside the rectum, more and more water gets absorbed from that stool, and it becomes desiccated and hard, and literally gets stuck and impacted into the rectum. The rectum becomes chronically stretched, and you lose that normal sensation, and this allows liquid stool to leak around the hard blockage without the child even being aware that they have to stool. Now, there are a lot of causes for this. Patients are very prone to developing constipation at 3 different times. One is when they're an infant and they start to have solid foods added to their diet. The second time is when children are toilet training, and they can often, as they start to learn to withhold their stool voluntarily to pass it down the toilet, sometimes they hold it too long and then it becomes painful to them. And then the third time is when children enter school, either because they're reluctant to use the public restroom or because they've had to alter their normal stooling schedule. Now, again, not every child who's constipated will develop fecal incontinence, but this is something that you really need to ask about. So on your history, what you want to do is make sure that this is retentive, functional fecal incontinence associated with constipation and not organic or non-retentive, because the treatment is very different. You want to figure out if there's any underlying disease process that may be making the child have fecal incontinence. Any neurologic symptoms the child may be having, symptoms of perhaps a metabolic disorder. Could they perhaps have thyroid disease? And that's why they're having constipation with an overflow. You want to know, are they taking any medications that could contribute to constipation, or even excessive caffeine use? So that can cause increased urine output, which can cause them to have harder, thicker stools. You want to get a careful history of whether or not there's been any abuse. Again, this would not go with retentive fecal incontinence necessarily, but more non-retentive. But even some children that have been abused will experience anal pain, and then they will start to withhold. And you want to get a careful family history. Not that constipation necessarily runs in families, but irritable bowel syndrome does, or even celiac disease. We commonly think about celiac disease presenting with diarrhea or malabsorptive stools, but sometimes it can present with constipation. Even a history of cystic fibrosis, obviously that could be definitely considered positive in a child who has constipation and maybe has a history of delayed meconium passage. You also then want to get a very careful stool history. What was the time to pass meconium? Most infants should pass meconium in the first 24 hours of life. You want to know, was the child ever continent for stool? If they never were, then I'd be much more concerned about this being a neurologic disorder. Then you want to know, what is the stool like? And the children always break out into laughter, nervous laughter, when you ask them what are their stools like. So it can actually be helpful to use something like the Bristol stool chart, which is shown here, to get a sense of what their stools are like. For a lot of these children, they're toilet trained, and so the parents are not in the bathroom with them. The parents really have no idea what the stools look like. When you ask the child, they don't really know either, right? They don't know how to describe it. They get very embarrassed. you can see here that type 1 stools, these hard pellet-like stools, these are very consistent with a history of constipation. But you can also have type 7 stools, where it's an entire liquidy stool, because this is liquid stool that's leaking around an impacted fecal mass. Normal stools are considered to be sort of type 3 and type 4 stools, so formed, smooth, not too hard to pass. You want to know if there's any pain with defecation, which again is very suggestive of constipation. You want to know how much stool are they passing. Children with constipation will often pass such large volume stools that they clog the toilet. And they won't offer this history. You have to ask it. You may say something like, have they ever clogged the toilet? And the whole family breaks out into nervous laughter. And the mother will say, well, yeah, we actually have to get the toilet brush and break up the stool so that we can flush the toilet. That's really indicative of someone whose rectum is very stretched and likely has constipation. And then you want to know, does the child even sense the urge to defecate? Again, with chronic constipation, their rectum gets so stretched that they don't have that normal feedback, and they can't sense when they have a large volume of stool there that needs to be passed. In terms of symptom history, the children often don't smell that they have stool in their underpants. And this is really weird because everyone else can smell it, but it just seems like over time they get very desensitized. So they don't know that they smell like stool, which can be really hard with their peers. They will often have a history of urinary tract infections. For girls, it can be because they have soiling in their underwear chronically, and that allows bacteria to get up into the urethra and into the bladder. They can also get urinary tract infections because their chronic contraction of the pelvic floor muscles withholding the stool can lead to dysfunctional urine voiding. When they do void, they often void incompletely, and then that urine that stays inside the bladder can become a breeding ground for bacteria. Up to 40% of children that have significant constipation with encopresis will also have enuresis. And this can be, again, because of dysfunctional urine voiding or because of the actual mass effect of the rectum on the bladder. Even though they may void or urinate completely, so they feel, because the bladder is pushed because of the distended rectum, when the children stand up, they experience urinary dribbling. And children can have significant abdominal distension. On your physical examination, again, always important to look at your growth parameters. Is this a child who's not growing well, which could suggest something like celiac disease? On your abdominal exam, you may be able to palpate stool in the left lower quadrant, which will feel like a firm but mobile and non-tender mass. A rectal examination is very important. Is there a skin tag, like is demonstrated in this picture, which could suggest underlying inflammatory bowel disease? You want to make sure they have normal neurologic function with a normal anal wink and tone, and look for any evidence of fecal impaction on your digital examination. If you're examining a boy, you want to make sure they have a normal cremasteric reflex, and check deep tendon reflexes, as well as a back exam to make sure there's no underlying spinal dysraphism. You may even want to check the extremities and make sure that you don't see any evidence of clubbing that could suggest cystic fibrosis. Now, in terms of diagnostic testing, really there's no routine testing that's required if you do a very careful history and physical examination. You may choose to do some selective testing based on what you uncover in your history and physical, something like thyroid function tests, celiac testing, or a lead level. As you all know, lead poisoning can cause constipation, and that would be something that you would be able to ascertain on your history. Abdominal radiographs are not necessary to diagnose constipation, but they can be helpful if the family needs convincing that that's what is going on, especially for those children that are having daily fecal incontinence. The family thinks that it's diarrhea, and they sometimes need to see the fecal impaction in order to understand and agree to comply with the recommended treatment. Barium enema and rectal suction biopsy would be needed if you're concerned about Hirschsprung's disease, and then a spine MRI if you think that the child may have an underlying spinal dysraphism. Now, treatment. Treatment really entails reassurance and education, disimpaction, and maintenance therapy. So you want to really tell the family and patient that this is common. Again, it's not intentional, just like enuresis, and that it is fixable. Punishment does not work, and in fact, the more they punish the child, the more the child will hide that they've had an accident, and the worse the problem will get. You want to tell families that this developed over time, and it's going to take a long time to get better. It's not going to improve overnight. There is no magic fix for this. You want to really stress the need for adherence to the treatment plan, and they will have to have very close follow-up with you to adjust their meds as needed. One of the most important things is you have to explain why you need to initially disimpact the child. Because if you don't have disimpaction first and you just put them on maintenance treatment, you're going to have worsened overflow incontinence. So in terms of treatment for disimpaction, the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition published a clinical practice guideline this year in 2014 for the evaluation and treatment of patients with functional constipation. Polyethylene glycol, which I'll refer to as PEG, and enemas have been found to be equally effective for fecal disimpaction. There is a higher frequency of fecal incontinence if you're treating somebody with high-dose PEG compared to enemas. But because PEG can be given orally as opposed to rectally, the Society actually prefers disimpaction with PEG. They recommend treating for 3 to 6 days, or if PEG is unavailable, doing daily enemas again for 3 to 6 days. There was no preference for which enemas to give, and there's a variety that can be chosen. Once somebody's disimpaction is complete, then you're ready to move on to maintenance therapy. The goal for maintenance therapy is to allow the child to have easy-to-pass stools on a regular basis. This requires a lot. The main key to maintenance therapy is medication. We talk about behavior modification, dietary changes, and time, but honestly, the only thing that has really been proven to be effective is medication maintenance therapy. Now, that's not to say that timed toileting isn't helpful. They should definitely try timed toileting after meals so they can benefit from that normal gastrocolic reflex. And they really want to sit on the toilet and try to have a bowel movement for 5 to 10 minutes. They really need very close outpatient follow-up again to be able to modify their maintenance therapy based on their response. These are the different maintenance medications, and the Society recommends PEG therapy, polyethylene glycol therapy, as the mainstay. This has been the most effective in all the studies that have been done. If for some reason it is not available, then lactulose would be your second-line agent. All the other agents listed here are considered third line and would not be recommended as primary therapy. The lovely thing about polyethylene glycol, as you also know, is that it is a powder and you can mix it in almost any fluid and it really will disguise the taste. So you don't have to fight with the child to get them to take it. Now, prognosis. Prognosis is surprisingly not very good. It takes a long time. So even in children who are referred to a gastroenterologist for treatment, half of them, 50 to 60%, are considered cured by a year. And cure is more than or equal to 3 bowel movements per week with no episodes of fecal incontinence. But half of those kids will have a relapse within 5 years. So it's really important that you explain to these families that this is a marathon, it's not a sprint, and you really need to work with them hand in hand and modify their therapy as you go along. So let's get back to the cases that we started this talk with. So case number 1, remember, he was the little boy who was having diarrhea after having had a stomach flu 3 months prior. And his mother is worried that he may have inflammatory bowel disease. So he was a former full-term infant with no significant past history. He was fully toilet trained since 3.5 years of age. And his family really didn't know what his prior stooling history was, but they started to pay attention more after he had the stomach flu. And since then, they noted that he was having diarrheal stools, 1 to 4 times a day, that were brown, foul-smelling, of varying amounts. And in the last month, he was starting to have accidents where he would pass gas, and unbeknownst to him, he would also have some stool leakage. He was unaware that this was even happening. His physical examination is only remarkable for palpable stool in the left lower quadrant, and he does have fecal soiling in his underwear. So for this child, there's really no indication for labs or x-rays. It's pretty clear that he likely had a viral gastroenteritis with fever and had decreased oral intake, and then subsequently developed constipation with overflow incontinence. Case number 2 was the 16-year-old girl whose mother was worried was pregnant. She had been also previously very healthy, fully toilet trained since the age of 2 and 10/12 years of age. But starting about 3 months ago, she was complaining about intermittent, daily crampy, periumbilical abdominal pains that seemed to be worse after eating or after activity, and would sometimes get better if she had a bowel movement. She reported that she stooled once a week, and she said typically they were very small pellet-like stools, but occasionally she had clogged the toilet. Her stools were brown, and sometimes she saw blood on the toilet paper, and she did say that she had pain with defecation. She refused to use the public restrooms because once she actually had clogged the toilet at the mall, and she was mortified. The patient describes herself as being type A personality. She's currently a junior in high school, and she wants to be a doctor. She's taking 4 advanced placement classes at school, and therefore she has no scheduled lunch period so that she can fit all her courses in. For the last 2 weeks, she has had occasional stool soiling in her underpants, which she's tried to manage by wearing sanitary napkins. Her mother noticed this, and she also noticed the daughter was looking bloated, even though she really hasn't gained weight. The daughter drinks a lot of coffee, 3 coffees a day, and maybe 1 bottle of water a day. And her physical examination only shows a slightly protuberant abdomen. So she also doesn't need any labs or x-rays, although you can do a pregnancy test if you want to placate the mother. Clearly, this child has been having chronic poor fluid intake as well as a limited diet with voluntary withholding due to refusal to use the public toilets that has led to constipation. So the treatment is actually the same for both of these patients, even though their initial causes were different. They both need disimpaction with oral PEG, and this would be something you would want the family to start on a Friday after school, or maybe if there's a holiday weekend. Then once they're cleared out, you want to do maintenance therapy with oral PEG and some lifestyle and dietary changes, and have really close follow-up. If you do these things, hopefully your children will improve over time, and they will have successful continence. Now I'm going to move to the last portion of my talk, which is abnormal sleep. The objectives for this lecture. By the end of this lecture, you should be able to describe what normal sleep is for children, discuss common sleep problems and how to evaluate them, as well as determine appropriate treatment strategies for your patients. First, I'm going to define what normal sleep is and discuss the epidemiology of normal sleep. Then I'll discuss abnormal sleep in children and cover the evaluation and treatment of patients that you may encounter in your office practice. Let's start with some cases again. Case number 1, parents that bring in their 2-year-old child, saying that they haven't had a good night's sleep since she was born. She's a previously healthy little girl who's always been hard for the parents to both get to sleep at night and to stay asleep. And now that she's out of her crib, they're at their wits' end, and the mother wants to know if there's a sleeping pill that she can give her. Case number 2 is a 6-year-old who's been very hard to wake in the mornings and has been marked tardy 5 times this year in school. His kindergarten teacher says that his performance is lagging behind his peers. And he's really been previously healthy, except he's been slow to gain weight, and his mother wants to know if she should homeschool him. So as you all know, there's huge benefits to sleep. Sleep is a neurodevelopmental process. It's as important as diet and exercise. It's not a passive maneuver. It's really vital for restoring our normal body functions. As you all know, growth hormone is secreted when we sleep, and it seems to be important in pruning neurosynapses. Sleep deprivation negatively impacts cardiovascular health, mood, and the ability to both learn and retain information. So what is normal sleep? So normal hours of sleep vary by age. Infants can sleep up to 20 hours a day. As you get older, the amount of sleep that your body requires decreases. By the time you're 12 months of age, most children are sleeping anywhere from 13 to 15 hours. By the time you're 1 to 3 years of age, that has gone down to 12 to 14 hours and continues to decrease until by the time most kids are teenagers, they need about 9 hours of sleep. Now, people always say sleeping like a baby, and that's a horrible expression because babies don't sleep well, right? They have very irregular sleep patterns. And especially in the first month to 2 months of life, their day-night sleep is completely messed up, and they often are awake more at night and sleep more during the day. They have these intermittent awake times of maybe 1 to 2 hours in length, interspersed with sleep times of 1 to 4 hours. Now, by the time an infant is 2 months of age, they've gradually started to increase their nighttime sleep, which is just about the time the parents are ready to drop, so they're really excited. And by 9 months of age, most infants will sleep through the night. They don't need to eat at night by this age for growth. And most of these children will have daytime naps, typically 1 to 2 naps per day, 1 in the morning and 1 in the afternoon, from anywhere from 2 to 5 hours total of nap time. By the time they're 18 months of age, most of these children nap only once during the day, and it's anywhere from 1.5 to 3.5 hours in length. Now, by the time the kids are in preschool, they usually stop napping by the time they're about 5 years of age, which is good because many of them then go to kindergarten, where it's hard to nap. Now, around this age, though, too, many begin to experience nighttime fears, and this is a time when some sleep disturbances begin. Now, in school-age kids, it is really rare for them to experience daytime sleepiness. They really should not, because they should be getting enough sleep. Now, interestingly, even though I said that most preschool children stop napping, culturally, many African American children will still nap, and as many as 39% of school-age African American children will still take a nap at the age of 8. Now, adolescents, sleep gets all messed up, right? Because their circadian rhythm shifts, and they start having melatonin secretion later in the evening, and it ends later in the morning. So that actually makes them want to go to bed much later and sleep in much later in the morning, too. And they often have very irregular sleep schedules. On the weekdays, they're up very early for high school, and they sleep in on the weekends. Now, the National Sleep Foundation conducted a telephone poll in October and September of 2003 of a random sample of adults who had a child 10 years of age and younger living in their household. Now, interestingly, they found that on this telephone poll, 69% of kids less than 10 years of age experienced abnormal sleep-related behaviors, including stalling or resisting bedtime, seeming sleepy or overtired during the day, waking too early in the morning for the parents' liking, snoring, or having difficulty waking in the morning. Now, this survey found that on average, children less than 10 years of age slept 90 minutes or less than what would be expected for their age. The survey also found that among children who woke at night, many of them required parental intervention. Now, as would be expected, the younger the child, the more likely the parent had to go to them and intervene to help them to go back to sleep. But even half the time, school-age children needed their parents to go briefly to them. So if the kids aren't sleeping, then the parents aren't sleeping. The National Sleep Foundation did another poll in 2014. This was another telephone interview. This time it was adults having children ages 6 to 17 years of age living in their household. More than 90% of these caregivers reported that sleep was either very or extremely important for their child's mood, health, performance, and behavior, as well as their own. This survey found a lot of abnormal sleep. So on average, these children 6 to 17 years of age were only sleeping 8.4 hours at night, which is less than what they need. 58% of children 15 to 17 years of age slept 7 hours or less. Of those children 6 to 11 years of age, 23% were sleeping only 8 hours, whereas they probably needed closer to 9. What they found on this survey is not really that surprising. 89% of adults and 75% of children have at least one electronic device in their bedroom. And if they do, the sleep duration is lower for those kids who leave their electronics on at night. Now, parents who had sleep rules about bedtime, those children had on average 1.1 hours more sleep than children whose parents did not have rules about bedtime. Children whose parents enforced rules regarding caffeine consumption later in the day slept 0.9 hours longer than children whose parents had no rules regarding caffeine consumption. And children whose parents always enforced rules about smartphone or cell phone use at night slept 0.8 hours longer. So it actually is important for parents to have good rules about sleep. So there are a lot of common sleep problems for children, and these are problems that cause inadequate quantity or quality of sleep. These can include behavioral insomnia of childhood, which is of 3 types: sleep onset association, limit setting, and combined type, parasomnias, and physiologic problems. So we'll talk about each of these individually. Behavioral insomnia of childhood is where children have difficulty falling asleep and or staying asleep, not because there's an organic cause, but because they've learned that they need certain things in which to sleep. So the sleep onset association type is where the patient requires very specific conditions in order to fall asleep. So the baby who's breastfed, whose mother has always breastfed her until the child falls asleep and then puts her in her crib asleep. Well, of course, if the child wakes and she's no longer in the mother's arms, she's going to cry and fuss until those same exact conditions are reproduced. These children have frequent night waking, and they require the caregiver to help them go back to sleep. The limit setting type are those children that stall at bedtime and they delay their sleep onset. These behaviors are so common, and the disorder becomes significant when it has a really negative impact on the caregivers. Now, the best prevention or the best treatment is prevention. You really want to educate parents regarding sleep and sleep hygiene early before they have these problems. But unfortunately, a lot of times we end up with patients that already have problems, and then we need to focus on treatment. They really need regular bedtime routines and a clear sleep schedule. There has to be a firm and consistent message from caregivers. The child cannot get away with something with the mother and then not something with the father. All the caregivers involved have to agree that they're going to do the same thing with the patient every single time. And there needs to be positive reinforcement. So when the child does fall asleep on their own, then the parents need to really reward them for this. Moving on to parasomnias. Parasomnias are undesirable events that are associated with sleep, and they typically occur during sleep-wake transitions. The patient appears to be having purposeful activity, but in fact it's not volitional. Most parasomnias occur during the first half of sleep, when the patient is in deep or slow-wave sleep, except for nightmares. There can be very precipitating factors. Sleep deprivation and genetics play a part. But in these children with parasomnias, there's no organic etiology to explain their symptoms. Night terrors are very common, affecting anywhere from 1 to 6.5% of children, presents most commonly between 4 and 12 years of age, and it decreases to an incidence of only about 2.5% in adults. This is of sudden onset. The child suddenly appears intensely fearful. They're tachycardic, diaphoretic, they're screaming. They're hard to awaken, though. So they seem like they're awake, they're screaming, but when you try to waken them, they're very hard to get fully aroused. And when you do waken them, they're often confused and they don't remember the event. The treatment really is parental reassurance. The child is not bothered by this. They don't know what's going on. But the parents are terrified, which is why we sort of call them night terrors. If these are happening every single night, they often happen at around the same time. So the parents can actually schedule wakings 15 to 30 minutes before when these episodes occur until the episodes stop, and that can take about 2 to 4 weeks. And then they often don't come back. Another parasomnia is sleepwalking. This is very prevalent as well. Anywhere from 1 to 5% of children will sleepwalk, often between the ages of 4 and 8. And this does have a genetic component. If one parent sleepwalks, the patient has a 45% risk that they will also sleepwalk. And if both parents sleepwalk, the child has a 60% risk that they may. With sleepwalking, the patient appears to be able to do all kinds of things, very complex motor activity, but they're fully asleep. They are also very difficult to wake, and if they wake, they have no idea what they were doing. Again, there needs to be a lot of parental reassurance, and you want to make sure the child is kept safe, and you may need to use gates and locks to keep the child from wandering outside. Another parasomnia is nightmares. Nightmares are very common. 10 to 50% of children who are 3 to 5 years of age will experience nightmares. Now, these are different because they occur in the second half of the night, and the children remember this. They wake with very, very clear recall of a very scary dream. And because of this, they can't go back to sleep because they're so scared. Now, the treatment for this is to not let them watch scary things before bedtime, don't read ghost stories before bedtime, and really provide a lot of reassurance to the child. A nightlight can help, explaining to the child that the dream wasn't real, having a favorite snuggly that they can keep with them, that you can tell them will keep them safe from their nightmare, can really help. But for some children, they almost develop a post-traumatic stress, and they may need referral to a behavioral health specialist for relaxation and coping strategies. And then moving on to sleep-disordered breathing. Sleep-disordered breathing can also cause sleep disturbance. Obstructive sleep apnea is where there's disruption of normal ventilation during sleep due to upper airway obstruction. And this is also very common, up to 5% of children, and it usually presents between 2 and 8 years of age. Now, children with craniofacial abnormalities or neuromuscular disorders often are at highest risk, but even children without these can be at risk. And the symptoms that you want to be able to elicit from the family is a history of snoring, children sleeping in strange positions with their head thrown back so their neck is hyperextended, children that may have witness apneas, or those who are described as very restless sleepers. They have daytime symptoms too. They may be a mouth breather, they may complain of morning headache, and they may have problems at school because they're not getting sleep at night. The history and physical examination unfortunately lack sensitivity to diagnose obstructive sleep apnea. This picture shows a child with what we call classic adenoidal facies. He's got the open mouth breathing, sort of a sleepy appearance, but unfortunately even children with this don't always have obstructive sleep apnea. What you need to do is do a polysomnogram, and this polysomnogram shows episodes of apnea listed in purple and episodes of hypopnea listed in yellow, with associated desaturation in the oxygen level located in peach. And the treatment for this would be adenotonsillectomy. Delayed sleep phase syndrome is another sleep disorder, and this is common in adolescents. 7 to 16% of them suffer from this. And this is when they experience a shift in their normal circadian rhythm, where their sleep-wake times are delayed by 2 hours or more relative to what would be considered conventional sleep times. These children have difficulty falling asleep and waking at the, quote, normal times that society expects of them, but they have normal sleep architecture. What you want to do is help them shift their sleep schedule to more normative hours, and then they really have to maintain this. They cannot sleep in on weekends. Narcolepsy is another organic cause of sleep disturbance. This is excessive daytime sleepiness with uncontrolled sleep attacks, and it presents typically at 15 to 25 years of age. It's a true neurologic disorder with episodes of cataplexy, which is sudden decrease in muscle tone triggered by strong emotion, sleep paralysis, hypnagogic hallucinations, and very early onset of REM sleep. The evaluation of this is polysomnography, but with a multiple sleep latency test. The patient is allowed to nap several times, and the time that it takes them to enter REM sleep is noted, and that's what helps us to make the diagnosis. Sleep specialists may prescribe stimulants to treat narcolepsy, and antidepressants have been used to treat cataplexy. But honestly, most general practitioners should be mindful that these type of sleep medications are often not FDA approved for children, and these children may be best off being referred to a sleep specialist. Restless leg syndrome and periodic limb movement disorder are also sleep disorders. They are both very similar. Restless leg syndrome occurs when someone is awake, and periodic limb movement disorder happens when they are asleep. In both of these disorders, there's excessive limb movement that causes either disruption in falling asleep or partial arousal during sleep. This is actually fairly uncommon in children. The prevalence is not well known. So when you see a child with sleep disorder, you want to take a very careful sleep history. The Bears sleep screening algorithm has been shown to improve identification of sleep problems in the primary care setting for children. The questionnaire incorporates 5 main sleep domains: bedtime problems, excessive daytime sleepiness, awakenings during the night, regularity and duration of sleep, and snoring. It has a set of age-appropriate trigger questions to use in the clinical interview. So for example, for the adolescent, you would say, do you have any problems falling asleep at bedtime? But for the toddler, you would ask, does your child have any problems going to bed or falling asleep? Based on the answers to the Bears screen, you can then ask more in-depth questions regarding their sleep domain. You want to know, what is their sleep routine? Do they always get a bath before bedtime, and then a story with the father, and then the mother comes and kisses them goodnight, and then the father comes back and turns on the nightlight? All these things you can see, whether the child gets used to a certain routine, they're going to need to have that repeated every single time so that they can go back to sleep. You want to know, what are their sleep surroundings like? A lot of families have shared bedrooms, and if the child is sharing a bedroom with an older sibling who goes to bed later, this may be impacting their ability to fall asleep at a normal time. You want to know the family history. Did the mother and father sleepwalk? Is there any family history of people that have had neuromuscular disorders or sleep apnea? And you want to know the social history. Has there been any disruption or stress in the family recently that may be contributing to nightmares? On your physical examination, again, you want to look at your growth parameters. Is this a child who is obese, who may be at more risk for obstructive sleep apnea, or a child who is in fact failing to thrive, which we will also see with obstructive sleep apnea, because every night the child is burning calories as they're breathing against the fixed obstruction. You want to do a very careful head and neck examination. This picture shows a little girl with adenoidal facies, again the open mouth breathing, and then the girl to her right with allergic shiners. If you have allergic rhinitis, you may have sleep disordered breathing because of decreased ability to breathe in through your nose and mouth. You want to do a careful pulmonary exam to make sure there's no evidence of wheezing. Nocturnal symptoms from asthma can disrupt sleep. A careful neurologic exam to make sure there's no evidence that this child has perhaps seizures or some other neurologic disorder. And then for your adolescent exam, you want to do a very careful history and physical examination to make sure that there's no substance abuse issues. Diagnostic tests are really not needed unless you're worried about obstructive sleep apnea. If you are, then you really need to do polysomnography, but otherwise there's no specific diagnostic testing other than a really careful history to elucidate what may be causing the sleep disturbance. So let's get back to our cases that we started our talk with. So case number 1, remember, was the 2-year-old who the parents are at their wits' end because they're not able to get to sleep, and the mother wants to know if there's a sleeping pill that she can give her. This child was exclusively breastfed for the first 6 months. She was always nursed to sleep until she weaned around 15 months of age. Her routine is that she's rocked to sleep in her room by her mother, usually, and once she's asleep, the mother very carefully places her in her crib, asleep. When she wakes, as the mother's doing this, she will sit back down, rock her again until she's asleep. This pattern repeats for approximately 1 hour every single night. Once they finally get her to sleep in her crib, the patient will typically wake 3 to 4 times at night, and she will cry and scream until one of the parents comes back into the room, picks her up, sits in the chair, rocks her, gets her back to sleep, and then very carefully places her back in the crib. The parents say they've tried it all. They said they tried the cold turkey technique and let her cry it out, but after 2 days where no one was sleeping, they gave up. And they do describe her as being very stubborn, and they acknowledge that she typically gets her way. The review of systems is negative for any snoring. The social history is pretty significant. The parents are experiencing a lot of marital stress, and they say that they're really desperate for help, which is why the mother wants some sort of a sleeping pill for the child. The physical examination is completely normal. So clearly this is a child who has behavioral insomnia of childhood of mixed type, right? She's gotten used to falling asleep in the mother's arms, and then she's used to having somebody come back in and put her to sleep, and she really rules the roost. There are really no bedtime rules for her. So what you need to do here is do a lot of parental education and reassurance. Now clearly this is a family that cold turkey is not going to work, so you want to do graduated extinction. Explain to them they're going to gradually teach their child how to sleep. And I think if you phrase it that way, explain to the family that just like they want to teach her how to read and teach her how to do good dental hygiene by brushing her teeth and teach her how to eat fruits and vegetables, they want to teach her how to fall asleep on her own. So gradually they're going to decrease what they do at night in order to get her to go to sleep and lengthen the time that it takes before they'll go into the room and intervene. So you really need to get buy-in from all of the caregivers because it's not going to work if the mother says she'll do it but the father doesn't. Case number 2 was the 6-year-old who the mother was complaining was really hard to wake up in the mornings and was starting to have problems in kindergarten, and the mother wanted to know if she should keep him at home to homeschool him. They described the patient's really easygoing. He's not a kid who fights bedtime. In fact, he'll often ask to go to bed even early. He will nap if they allow him after school, and he always naps on weekends. He does snore at night. In fact, the family jokes when you ask him, and they say, yeah, he's louder than the father when he snores. They've never thought that that was strange. His weight gain has been slow, but other than that, he's really developed very normally. His physical examination reveals that he is somewhat underweight, with a height of 25th percent, but a weight less than 1%. He has adenoidal facies on exam and a normal cardiac exam. So your diagnosis would be obstructive sleep apnea or sleep disordered breathing. This child may need a sleep study, or based on your history, which is pretty striking, you may want to just refer that child to ENT for definitive treatment.